Bismillah ar-Rahman ar-Rahim. In this lecture, I'm going to give you an overview about the infertility. Actually, we are not frequently using the term infertility. We are now using the term subfertility because, theoretically speaking, after the advent of the assisted reproductive technology, all couples are capable of achieving pregnancy. The simple requirements for conception are: the male rule is the production of healthy sperm and capacity of deposition of this sperm inside the vagina during intercourse. However, the female rule is a bit more complicated. They have to produce healthy eggs from the ovaries. They have to have healthy tubes which is capable of picking up these oocytes and give them the environment for fertilization in the ampullary portion, transmit them after fertilization into the uterine cavity. The uterine cavity should be healthy. They should have healthy cervix, vagina, or even vulva. Traditional definition of infertility is the inability to conceive following unprotected continuous marital relationship for at least 1 year. If you look at the graph in the bottom of the slide, you'll find that 60% of the couples get pregnant within 6 months of marriage. After 1 year, about 80% of them become pregnant, and in 2 years, 90% are going to become pregnant spontaneously. And it's only 10% after 2 years are going to remain needing for treatment to become pregnant. However, it's very unfair to deal in the problem of infertility with a patient who is less than 30 years, like a patient who are near 40 or above 35 years, because of the deterioration of the quality of the oocytes and the increased chance of infertility with increasing age of the female. So we like the definition which is linking between the duration of marriage and the age of the female. So we consider infertility as an ability to conceive following unprotected sexual intercourse for 2 years in the females less than 30 years. It's 1 year for the female between 30 and 35 years, and it's only 6 months for the females above the age of 35. Traditionally, we used to divide infertility into primary infertility for the couples who has never conceived before, and secondary infertility for the couples who had a previous pregnancy, whatever the outcome it was, abortion, intrauterine fetal death, full-term delivery, etc. The importance of this classification is that it points to you where the problem could be. Primary infertility usually is ovarian factor infertility, and the secondary infertility is due to tubal factor infertility. If you look at generally to the cause of infertility, we will find that they are divided equally between male and female. 30% of the causes of infertility is due to female factor, whether it is ovarian, tubal, uterine, cervical, vaginal, or vulval. And 30% is due to the male. 30% there should be a problem in both male and female at the same time, and it's only 10% when you will find that the male and female are normal but they are not conceiving. This is what we call unexplained infertility. This is the most important question you should retain in your mind. What is the basic evaluation of the infertile couple? If you have an infertile couple, you should take history from them. You should do physical examination for the female, general, abdominal, and local. And then you should ask for semen analysis for the husband. You should look for the ovulation of the female in whatever way, as we are going to explain later. You should ask for histosomnography. Postcoital test may be or may not laparoscopy. So if you have a question about what is the basic evaluation for the infertile couple, so we are concentrating on these 4: semen analysis, determination of ovulation by day 21 to 23 serum progesterone, histosomnography, and postcoital test. Briefly, we are going to pass by the male factor infertility. As I told you before, the rule of the male is to have a good sperm and have the capacity of deposition of these sperms inside the vagina by intercourse. So Inability to do the intercourse is due to simple factors like impotence, premature ejaculation, retrograde ejaculation, cases of severe hypospadias or marked obesity. And the semen analysis is simply done by what we call computerized assisted semen analysis, or the autosperm. We ask the male to abstain from intercourse for 2 to 3 days, come to the lab, collect the ejaculate by masturbation, whatever way. Then the analysis is going to be done within 1 hour. If we have a good semen analysis, then we can exclude at least 90% of the male. We have 2 sets of criteria for considering the semen analysis normal or not. We have the WHO 1999. Those in the red color are those numbers I'd like to retain in your mind. Sperm count 20 millions per milliliter or more. The motility is 25% grade A motility, which is the rapid forward progressive motility, or the total forward progressive motility A and B is 50%. Morphology, at least 30% of the sperms are normal in their shape and structure. However, in 2010, WHO produced another set of figures to what's considered to be normal. They considered the sperm count 15 millions per milliliter or more, or 39 millions total count is to be normal. The motility is 32% forward progressive, or the total motility, whatever its type, is 40%. And the morphology is 4% only of the sperms if they are normal in structure and shape is considered to be normal. These are some terms I think you are acquainted with because you had andrology last year. Aspermia, which is absence of seminal fluid. Azoospermia is total absence of sperms. Oligospermia is a few number of sperms below the normal, according to whatever criteria you are using, 15 millions or 20 millions. Athenospermia is weak motility of the sperm. Teratospermia is the increased abnormal morphology of the sperm. Necrospermia is the presence of dead sperms. Biospermia is the presence of pus. And hematospermia is the presence of blood in the seminal fluid. Now let's come to the female factor infertility, this target of our lecture. We will start with the ovulatory defect, which represent about 20-25%. This is the commonest cause of infertility in the female. So when we ask you about the primary infertility, the commonest cause is going to be the ovulatory factor, 20% of the cases. Disorders of ovulation are really important, and before going into the depth of this subject, I'd like to remind you a simple diagram which represent how the menstruation occurs. If we imagine that the scenario of the first menstruation of the female start by stopping the cerebrocortical inhibition of the hypothalamus. When the hypothalamus is released from this inhibition, so it's going to produce gonadotropin releasing hormone, one of the releasing hormone you are acquainted with, like any other releasing hormone in the endocrinology you have studied before. Gonadotropin releasing hormone is going to stimulate the anterior pituitary to produce the follicle stimulating hormone. From its name, you can imagine that it goes to the ovary, stimulate the primordial follicle which are present in the ovary, and then cause them to grow to become mature Graafian follicle. This is going to take the first 14 days of the cycle, during which the estrogen, which is produced by the growing follicles, going to stimulate the basal endometrium to become proliferative endometrium. When the estrogen reach peak in the middle of the cycle, the day 14, around the day 14, because of the full growth of the follicles, it's going by negative feedback stop the production of gonadotropin releasing hormone and the FSH. And this stop the growth of the follicles or any other follicles to grow. And at the same time, it increases the production of another hormone which is called the luteinizing hormone. The luteinizing hormone is responsible for what's called ovulation, cause rupture of the mature Graafian follicle. The oocyte is going to come out, and the remaining is called the corpus luteum. Corpus luteum will continue to produce hormone, mainly the progesterone. Progesterone is going to work on the proliferative endometrium to become thicker and become secretory endometrium. After another 14 days, a spontaneous degeneration of the corpus luteum is going to occur. This will drop these hormones, menstruation will occur, and the FSH and the LH will be released from the negative feedback, and another cycle will start again and again and again. So this simple diagram, which represents how the menstruation occur, is very important for you to understand how the anovulation is going to occur. So disorders of ovulation are many. The anovulation, luteal phase defect, the LUF or luteinized and ruptured follicle, but here we are going to concentrate on the anovulation problem. Before going to the cause of anovulation, how we can diagnose ovulation? This is an important question you are going to face in the Viva exam or in the written exam and in the clinical life. So it's like any other diagnosis, clinical and investigation, symptoms and signs and investigation. Symptoms which denote that the patient might be ovulating are regular cyclic menstruation. When the female is telling you that the menstruation is coming regular every month or every 28 days, it's not necessarily always, but it's mostly regular ovulation. Second is ovulation pain, which is a pain that the female experiences at the time of ovulation due to rupture of the mature Graafian follicle. Maybe some drops of blood come out during the time of ovulation. It usually continue for 1 day or a few hours. Ovulation cascade, which is all the female experience increased vaginal discharge, which is clear vaginal discharge around the time of ovulation. Some tenderness in the breast and breast pain, premenstrual tension syndrome. Some of the females experience some flushing effects of the progesterone second half of the cycle. Maybe the pain which occurred during the first and second day primary dysmenorrhea of the menstruation. All these are symptoms of ovulation, and you can see that most of them are pains. What about the signs which might denote ovulation? The biphasic basal body temperature chart. This chart in the old days was given to the female. We asked her to measure her temperature first thing in the morning before getting out of the bed and mark it on this graph. You will find that if she is ovulating, that there is an increase of ½ degree centigrade in the second half of the cycle due to the thermogenic effect of progesterone. So if you see the chart biphasic like this, with the increase in the temperature in second half of the cycle, it means that she is ovulating. But if it is monophasic and there is no increase in temperature, it's usually because she is anovulatory. There usually changes in the character of the cervical mucus occur around the time of ovulation. Under the effect of estrogen, the cervical mucus become copious and thin and stretchable, what we call it spin parquet sign. And when you put a drop under the microscope, it will take the palm leaf appearance, what we call the ferning sign. This is not clinically that important, but all the female know that the copious thin discharge occur around the time of ovulation. This because it will be more receptive for the sperms to pass through the cervix. But when ovulation occurs, actually it becomes thick and tenacious and represent a plug which closes the cervix and prevents any other sperms from ascent after the time of ovulation. The change of the character is actually a sign. What about the investigations? Investigations are more important now in the determination for sure that ovulation is occurring. What's important is the serum progesterone in the second half of the cycle, day 21 to 23 of the cycle. If the serum progesterone is more than 10 to 15 nanogram per deciliter, it means that the lady is ovulating. There is now commercial kits for detection of the LH. As I told you in the diagram first, that LH surge is responsible for the occurrence of ovulation. So if the female is testing her urine every day and she found that there is positive LH surge, so she can expect that ovulation will occur in 32 to 36 hours from the surge of LH. By using of the transvaginal ultrasound scan, so you can see a picture like this with Graafian follicles are there. These are not the oocytes, these are the cysts which could contain the oocytes inside, which is a microscopic structure. So this is not a picture denoting that there is ovulation. It means that we have impending ovulation if the size of the Graafian follicle is between 18 to 22 or 23 millimeters. But you have to do it in 48 hours and see that this cyst has disappeared, so it means that ovulation occurred. Accidentally, during laparoscopy, you might see the stigma of ovulation denoting that ovulation is impending to occur. Old days, we used to use the perimenstrual endometrial biopsy to send it over to the pathologist. If he says it's secreted endometrium, it means that the female had ovulation in the previous cycle. But we used not to do all these things now. We are now just focusing on the serum progesterone in day 21, 23. If it's more than 10 to 15 nanograms per deciliter, it means that the lady is. So, what are the causes of anovulation? Anovulation could be physiologic or pathologic. Anovulation occurs before puberty, in the peripubertal period in the first 1 to 2 years after the occurrence of puberty, during pregnancy, during lactation, and definitely postmenopausal. These are times where there is no ovulation physiologically. Pathological anovulation. Pathological anovulation occurs according to the diagram I told you before. Disturbance of this axis, hypothalamo-pituitary-ovarian axis. So the causes are either up there due to hypothalamic and pituitary problem, or down there due to ovarian problem. That's simply the cause of anovulation. The WHO had a classification for the causes of anovulation. The type 1 WHO is called the hypogonadotrophic hypogonadism. And the second type is the hypergonadotrophic hypogonadism. The WHO type 3 is eugonadotrophic hypogonadism, and the type 4 is due to the hyperprolactinemia. Maybe it looks a bit complicated, but let me show it to you in a very simple way. First, the hypogonadotrophic hypogonadism. From its name, hypogonadotrophic means that gonadotrophins are not coming out of the pituitary gland. So why? Maybe due to hypothalamic causes or pituitary causes. We are not, on the level of the students, interested that you retain in your mind all these syndromes which are associated with hypothalamic problems or pituitary problems, but you can imagine there is a problem in the hypothalamus, whether it's organic lesion due to trauma, inflammation, or tumors. Maybe it's congenitally not producing gonadotrophin-releasing hormone like the Kalman syndrome, or it has a disturbance in its function due to stresses, severe exercises, anorexia nervosa, etc. And the problem might be in the pituitary. It's not responsive to the gonadotrophin-releasing hormone coming out of the hypothalamus. Maybe congenital syndrome, Sheehan syndrome, which is a postpartum apoplexy, occurs in the pituitary gland due to severe postpartum hemorrhage. Maybe trauma due to surgery, irradiation, inflammation, tumors, etc. But what I want you to know in your mind that there is a hypothalamic or pituitary problem. So there is no gonadotrophins are coming out. So if you have a patient like that, how can you treat it? We will give what's absent. If we have a hypothalamic problem, then we can give the patient gonadotrophin-releasing hormone, which is not secreted from the hypothalamus due to whatever reason. we have the gonadotrophin-releasing hormone, but the problem is it should be given in a pulsatile manner through a pump like that of the insulin. But this is not practical clinically, and we only use it in the research remit. But let's look again. Gonadotrophin-releasing hormone will stimulate the pituitary gland to produce the gonadotrophins. So the end product is a gonadotrophin. That's what's important to stimulate the ovary. So why not to give the gonadotrophins? So whatever the we can give either in the hypothalamic problem or the pituitary problem, we can give the gonadotrophins because we have it. It's simple, straightforward. We give it intravascular, subcutaneous, or whatever way. We have FSH and LH, FSH alone, LH alone. We have all these varieties. So usually hypothalamic and pituitary problem both together are treated with gonadotrophin therapy. But the problem with the gonadotrophins is that we do not know exactly the dose the patient is requiring to produce one follicle. So usually you have the problem of multiple pregnancy, or what we call ovarian hyperstimulation syndrome, which sometimes is severe enough to cause death of the patient. And we are going to talk about both later. This is type 1 hypo patient. What about the hypergonadotrophic hypogonadism? From its name, it means that we have a high levels of gonadotrophins, but we do not have ovulation. So the problem should be in the ovary. That's right. The problem in the ovary, whether it is congenital, straight gonads like Turner syndrome, resistant ovary syndrome, the ovary has a premature ovarian failure due to trauma, due to irradiation, due to chemotherapy, chronic inflammation, might happen spontaneously. Whatever the etiology, the ovary is not responsive to the gonadotrophins produced from the pituitary gland. And what will happen if it is not responsive? There is no estrogen, progesterone produced, so there is no negative feedback suppression, so the gonadotrophins continue to rise. How can we treat this? Unfortunately, there is no current treatment, because the only treatment is to get oocyte for the lady if she would like to become pregnant. Maybe in the future, the stem cell is going to help manufacturing new oocyte in the absence of oocytes in the ovary. Type 3 is eugonadotrophic hypogonadism. We don't have a problem in the gonadotrophins. We have FSH and LH. We have an ovary which is responsive, but there is no ovulation. Why this is going to occur? Those patients are due to what we call polycystic ovary syndrome, and you will have a complete lecture about the polycystic ovary syndrome, because this is a very, very important subject to know for the infertility and other problems caused by the polycystic ovary. Lastly, definitely, is the hyperprolactinemia, and you will have a lecture separate for the hyperprolactinemia. If we move to the tubal factor of fertility, which is the cause of infertility after the ovarian factor, represent about 15 to 25%, and it comes first if we are speaking about secondary infertility, as I told you before. The fallopian tube is a very delicate structure. Its caliber reach about 1 millimeter in some of its part, the ethmical part, and it play a very crucial role in, as I told you before, picking up of the ovum and giving an environment for fertilization to occur in the ampullary portion of the tube, and then moving it by ciliary movement to fall inside the uterus and the implantation to occur. So the tube, if the tube is going to be exposed to any problem, whether it is congenital, endometriosis, trauma, salpingitis, or tumors, then it's going to lose its function. And if it loses its function, it will play a crucial role as the cause of infertility. But if we will ask you what is the commonest cause of tubal pathology, it will be the infection, salpingitis. And what is the commonest infection causing this problem? Is a chlamydial infection. The second commonest cause is going to be the endometriosis. 10% of the female walking on earth has got endometriosis. 30% of the female with infertility problem has got endometriosis. The third important cause is the trauma to the tube. And trauma to the tube occur in the previous ectopic pregnancy, tubal sterilization, or peritubal surgery, removal of ovarian cyst or whatever. How can you evaluate the tubes, if they are good or not? Definitely we'll take history from the patient, we do examination to pick adenic cell masses or whatever, but investigations are very important. The first investigation is going to be hysterosalpingography. Hysterosalpingography, from its name, it's a dye which is injected through the cervix to go into the uterus. We take a serial picture to follow its passage into the tube and then outside the tube into the peritoneal cavity. Normally you see the uterus like this, triangular in shape with the dog ear appearance of the entrance of the tube. Tube is thin, mildly dilated at the ampullary portion, and then spilling the dye easily outside into the pelvis, and is going to spread smoothly into the pelvis. But if you see, like picture that on the right top, you'd see that the dye is accumulating in the left tube due to obstruction of the end of the tube, so it's become ballooned. This is a classic picture of the hydrosalpinx, for example. The second investigation is the sonosalpingography. Sonosalpingography is depending on idea like that of the hysterosalpingography, but with the use of the transvaginal ultrasound scan. You see, we put the transvaginal ultrasound scan inside the vagina. We put special catheter with the olive pulp to close the cervix. The catheter inside the uterus. We inject the fluid inside the uterus. With the transvaginal ultrasound, we can observe the fluid which is filling the cavity and then passing to the tube. If you are expecting a pathology inside the uterus, closing the ostia of the tube, so the hysteroscopy is going to diagnose and treat this pathology. Like the picture on the bottom right, you can see the fibroid which is filling the cavity, is obstructing the proximal end of the tube. Standard diagnosis for the tubal fracture is the laparoscope. With the laparoscope you can see all the pelvic structures, the uterus, the tube, see the ovaries, the Douglas pouch, and you can see in the lower bottom right picture there is adhesions around the left tube of the patient. The omentum and the bowel are covering the tube, and definitely this tube has lost its function. How can we treat the tubal fracture? If we have a problem with the tube, we will try to restore the tubal function by the tubal reconstructive surgery. Whether we do it using the laparoscopy or microsurgery, microsurgical open techniques. Remove adhesions, make an ostia in the tube, do femperioplasty, tubal reimplantation, stenosis is going to remove, resection, reanastomosis of the tubes. It depends upon the pathology present in the tube. However, it's ideal for the tubal fracture infertility to use the assisted reproductive technology. Briefly, I'm going to speak to you about the assisted reproductive. I think you will have a full lecture about. The assisted reproductive technology, it means handling of the human eggs, sperms, or embryos for the purpose of establishing pregnancy. And any technique which entail dealing with the sperms, with oocytes, with the embryos, then is going to come under the title of assisted. So traditionally we used to have a lot of techniques, but now we have 3 only remaining techniques you have retained in your mind: the IUI, or intrauterine insemination, in vitro fertilization, which is the IVF, ICSI with intracytoplasmic sperm injection. What's IUI, or intrauterine insemination? Simply, from its name, it's taking the semen injected inside the uterus instead of the natural intercourse. Why we should do this? Maybe there should be a mild athenospermia. The sperms are not quite active, so we carry them, inject them in the top of the uterus near the entrance of the tube. Maybe the cervix has got a problem, stenosis or immunological factor, so pass by the cervix, inject the sperms inside the uterus, maybe in some cases of unexplained infertility. However, according to the new guidelines, the rule of the IUI has regressed a lot because of its limited value. Its pregnancy rate is similar to the natural intercourse if the patient doesn't have a problem. So the new indications for IUI according to the guidelines are failure of intercourse due to impotence or retrograde ejaculation, or if the semen need to be washed, like the patients with HIV. HIV males, if they would like to give birth for a baby, then we take the semen sample, wash them to get rid of the virus, and then inject it inside the uterus to prevent the transmission of infection. But we are not injecting the whole semen as it is naturally. We have to process it to increase its activity and select the best sperms. We have a lot of techniques for selection, but the commonest is the swim-up technique. Then we take this pellet, and then whether we are going to inject it inside the vagina, in the cervix, in the uterus, intratubal. However, the commonest technique was the intrauterine insemination. Let's come to the important point, the IVF. So why we are going to do the IVF, or the in vitro fertilization, or fertilization outside the body? If you have a tubal problem, you can imagine that the tubes are bilaterally blocked, you cannot open it by surgery. Then what you can do? Take the oocytes outside, fertilize them outside, inject the embryos inside the uterus, so you pass by the tube. Or you have very few sperms, you obtain it from the normal semen or the semen sample, or directly from the testicles or from the epididymis. Then you cannot just inject it inside the uterus because they are not going to cause pregnancy. You have to do this technique, and in some cases of unexplained infertility. The first baby delivered, actually, Louise Brown delivered by the technology of the IVF. It was on the 25th of July 1978 in UK. And these are the two pioneers who did the first baby by the IVF: Patrick Steptoe, the gynecologist; Robert Edward, the embryologist, professor of pathology in Cambridge University. And this actually was a breakthrough in science. And this is the Evening News, which announced the Louise Brown, the first world test tube arrival. And Patrick Steptoe passed away in 1989. Robert Edward died in 2012. In 2010, he got alone the Nobel Prize in medicine for their achievement, but after a long time for the delivery of the first baby due to political problems, actually, about the technology. This is simply how the IVF is done. We stimulate the ovulation, absorb the oocyte, put them in the dish with the sperm in the incubator. After 48 hours, we look for fertilization. We leave them for division. Then we take the embryos in day 3 to day 5 to inject it inside the uterus. But you put them together, but there is no fertilization. You need to have a step forward, which is the ICSI, intracytoplasmic sperm injection. That's where we take the sperm and inject it inside the oocyte. So we pass by the step of fertilization as well. So we use the ICSI in cases of failure of fertilization in IVF before, or in case of severe male factor, oligoazoospermia, athenospermia, teratospermia, in all these conditions we go for ICSI. Whatever technique we are using, it has definite steps. We are going to show you rapidly how we do the IVF or ICSI. First, we have to stop the pituitary gland, because if we are going to control what's happening during the technology, the body shouldn't interfere. So the first step is stop the hypothalamo-hypophyseal ovarian axis. This either by gonadotropin-releasing hormone agonist or antagonist. And after completion of this step, then we will start our stimulation. We decide which dose the patient is going to take. We give her the injection over 10 days or 12 days according to the response of the patient, and then by the end of these 10 to we will have oocytes present in the ovary. So we have to collect them. How we collect them? They started first by laparoscopy, and now we do it by transvaginal ultrasound scan. We put the transvaginal ultrasound scan inside the vagina, take a picture of the ovary, then we introduce a needle mounted on the transvaginal probe, and then we advance it through the Douglas pouch into the ovary, and you can see in the upper right picture how the needle appears in the transvaginal ultrasound scan inside the follicle. Then we aspirate them, so we collect the oocytes outside. Then we should have the sperms. Either we take it by ordinary sample, or we take it from the testicle, from the epididymis, according to the condition of the male. Then, instead of putting them together like the IVF, going to put them under the microscope. Each oocyte, you can see here the oocyte, we are holding the oocyte, and then we introduce a needle and then inject the sperm inside. And this is the inverted microscope. We use it for the injection process. It has a holding and injecting handles, and we hold each oocyte under the microscope, injected with one sperm. Then we put the injected oocyte in incubator for 3 to 5 days. These are different styles of incubators. And what will happen? Fertilization and cleavage. You can see in the picture of oocyte at different stage. This is the fertilized oocyte, and then it's going to divide into 2, 4, 8 cells, etc., until we reach finally to the blastocyst stage. This is the stage which implant naturally inside you. Then we come to the embryo transfer. We will take the embryo, whether in the day 3 or day 5, using this catheter. We are going inside the uterus. But before injection, we might need to hatch or help hatching the zona pellucida. The zona pellucida remaining around the embryo. The embryo is going to hatch through the zona to implant itself inside the uterus. But sometimes you will find that the zona is thick, so we have to help the embryo by making a small hole in the zona, either to do it mechanically, by laser, or chemically. This is the laser machine where we hit the zona carefully in 1 or 2 sides, just to make a hole and allow the embryo to hatch. Then we mount the embryos on the catheter, then introduce it inside the uterus. You can see it under the ultrasound scan in the top right picture, and we inject it in the optimum point of implantation. This is a complicated technology. It's not without complication. As I told you before, due to stimulation, you might have ovarian hyperstimulation syndrome, multiple pregnancy. Maybe the repeated stimulation of the patient collecting oocytes is going to reduce her reserve, so premature ovarian failure might occur. Maybe the repeated trauma of the ovary is going to stimulate epithelial malignancy to occur. Nobody knows, but it's not without complication. During this technology, we have a lot of advancements occur over the past 2 decades. One of them is a pre-implantation genetic diagnosis. You can imagine that you have the embryo outside. So you can take one cell of the embryo, test it for whatever testing you'd like. For example, you can know if this embryo is male or a female if you are looking for sex selection. Or if the family has got babies before with congenital malformation due to chromosomal or genetic problem, then you can choose only the healthy embryos to transfer to the female. Also, the freezing technology is a new technology which is very beneficial to the females. For example, if you have an extra embryos and those you are going to transmit to the patient, don't throw them away, you can freeze them. And freezing can continue from 20-25 years, and the patient can have this set transferred to her after 1, 2, 3, or 5 years according to her age. You can imagine that we can freeze embryos, freeze gametes, sperms or oocytes. We can freeze a whole ovary or part of the ovary. You can imagine a patient who is young, has got non-Hodgkin lymphoma. She is going to have chemotherapy. This chemotherapy theoretically is going to destroy her ovary. She will be surviving after the non-Hodgkin lymphoma, but unfortunately she is going to be totally infertile. What is the solution? Just before going into the treatment, we are going to stimulate her, get her oocytes outside, freeze them. She go for chemotherapy. If she has a problem with her ovaries, then she has in the bank oocyte. She can use it for making babies later on. So freezing technology is a new technology, but it's totally beneficial to the patient. Now let's come to the less important factors, the uterine factor infertility. I told you it represents about 2 to 3% of the etiology of the infertility. It's either congenital, traumatic causes, endometritis, which is a chronic infection like tuberculosis, and fibroids. All these might cause infertility. How can we diagnose uterine factor infertility? As anything else, history, examination, do investigations like transvaginal ultrasound scan, histosalpingography, sonohysterography, and hysteroscopy. So you can pick problems present inside the uterine cavity. What is the cause of infertility among those congenital anomalies you see in the picture? Unfortunately, none of them. Maybe the septate and subseptate uterus are responsible for some recurrent abortion, so we can remove it using hysteroscopic resection. Asherman syndrome, which is the presence of intrauterine adhesions caused by over-curettage of the uterus or a chronic infection. In this case, there is no space for implantation to occur because there is a fibrosis of most of the endometrium. We go with the hysteroscope, try to cut the adhesions, stimulate the patient to have rebuilding back of the endometrium. Fibroids are not very important cause of infertility unless you have a big fibroid which is filling the uterine cavity. So if we give you this picture, ask you which fibroid is going to interfere with pregnancy, it's only one in the middle, which is the submucous fibroid filling or distorting the uterine cavity. We go with the hysteroscope through the cervix and remove this fibroid. Cervical factor infertility, its importance has regressed a lot. Only 1 to 2% of the cause of infertility may be claimed due to cervical factor. What causes in the cervix? Congenital, traumatic, infections, immunologic factors, maybe neoplasia like cancer cervix or fibroid. What's important I'd like to tell you here is the postcoital test. Postcoital test is a very controversial test. We used to do it in the old days. We ask the patient, its value actually is to test the behavior of the sperm inside the cervix and the vagina. We ask the patient around the time of ovulation to have a normal intercourse, and then come to us within 4 hours of intercourse without douching or without evacuation of the bladder and rectum. Come to us, we will take sample with a catheter from the vagina and cervix, put it under the microscope, and look at the sperms in both samples. If we have no sperms in the vagina or the cervix, so there is no intercourse or the husband is azoospermic. If we have these sperms in the vaginal sample and no sperms in cervix, so all the sperms died in the vagina, none of them go into the cervix. So it's hostile vaginal secretions. If we have living sperms in the vagina but they are dead in the cervix, so the problem will be in the cervix, whether immunologic or hostile cervical secretions. If we have living sperms in both the cervix and the vagina, so it's normal. How can we treat cervical factor? If we believe that cervical factor is existing, if there is an etiology, should be removed. Intrauterine insemination is going to help. Lastly, the unexplained infertility. Unexplained infertility is patients whom we cannot find causes either in the male or in the female. They are both normal, but there is no pregnancy occur after 1 or 2 years. There is a protocol which everybody agreed upon. We wait and see for 1 to 2 years according to the age of the female. If there is no pregnancy, we are going to increase the capacity of our ovulation by ovarian stimulation, and point the time of intercourse. This is going to be repeated for 6 cycles. If there is no pregnancy, we will do again the ovarian stimulation, but with IUI for 3 to 6 cycles. So within 2 or 3 years, according to the age of the patient, we will send the patient to IVF and the ICSI program if she is not pregnant. I wish you all the best. Thank you very much.